Hello, I'm Dr. Matias Lopez Chacon. I'm a pediatric neurologist and I specialize in pediatric neuromuscular medicine. I'm going to be talking about a recent presentation that I did on the evaluation of the hypotonic child. Hypotonia is one of the most common signs and symptoms that neurologists will see in the outpatient settings. The majority of the times, hypotonia is present at birth, however, it becomes more apparent as the child grows older, therefore sometimes it can be missed. There are occasions where the hypotonia can be due to a neurological cause, but other times that it can be due to endocrine problems, metabolic problems, or genetic problems. Therefore, if we're able to answer a combination of signs and symptoms will lead us to a better diagnostic approach, such as, is hypotonia accompanied by weakness or not? Where is it located at? Is it diffuse? Is it only on the axial body, or is it more appendicular? Which one is more prominent? Hypotonia or weakness? Are reflexes present or not? Once we're able to answer all those questions, we might be able to come with a better diagnosis, such as central hypotonia. Central hypotonia refers to anywhere that lies within the brain and the spinal cord, versus peripheral hypotonia means the nerve, the muscle, or the connection between those two, and they are different. In cases of central hypotonia, the child will have other signs and symptoms, such as altered levels of consciousness, abnormal eye movements, difficulty chewing, swallowing, speaking, other delays, the global developmental delays. The reflexes will be increased, and there can be a change on tone towards high tone, particularly in the appendicular areas. Whereas peripheral hypotonia tend to have an alert child, very interactive, but very weak. Therefore, weakness and hypotonia are at most. In those cases, the reflexes are decreased, and they tend to remain as such for the rest of their life, or sometimes they become just a little more weak than that. Once we have established that, we can do a more tailored approach towards our diagnostic odyssey. We can start by a very good physical examination, history, and after that decide where we're going to get MRIs, imaging of the brain or the spine. Most of the times we need to go further down the line with metabolic testing to see if there's any problem in the chain of metabolism. And some other times we have to do genetic testing either in the form of a panel or next sequencing generations, such as whole exome sequencing or whole genome sequencing in mitochondrial DNA analysis. And finally, in my specialty, I perform reconstruction studies and EMGs in those cases that needs further resolving. And if that doesn't lead us an answer, we can still do a muscle biopsy. When I think about neuromuscular problems, I always try to figure out, is it coming from the nerve, the muscle, or the neuromuscular junction? In cases of muscle problems, the weakness tends to be more proximal, big muscles, shoulder, hips, whereas the nerve problems tend to show more on distal areas, hands, feet, accompanied by sensory symptoms, the lack of them, such as numbness. In both cases, reflexes will be absent or diminished, and they would remain as such throughout life. So once we have able to pinpoint where is this weakness in hypotonia coming from, we can tailor our next steps, whether it's starting with a nerve conduction study or starting with a genetic test. And after that, we should be able to give the family a better prognosis and what to expect. With this, I would like to conclude my presentation. Thank you.